Assalamualaikum.
Waalaikumsalam, doktor.
Assalamualaikum.
Waalaikumsalam warahmatullah.
Okay, let us start by Al-Kitab. Hello. Can you hear me?
Yes, doctor.
Yes, doctor.
Let's go for the first case. You have 15 minutes between both of you to discuss. Okay.
So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. My name is Shahira, and I will be the doctor for today. The patient is Hassan, will
I'm
be
Hassan.
Mrs.
Yeah, I am Hassan to be the patient today.
So, Assalamualaikum Mrs. My name is Shahira. Okay. So, may I ask what brings you here today?
To my child, they have apa dah? To breathe fast breathing last
Okay,
night.
so your child has fast breathing. For how long had he had that fast breathing?
Since 8 o'clock last night.
Since 8 o'clock last night. And currently the time is 10. Okay. So, may I ask, your child, is it a girl or a boy?
A boy.
A boy. So how old is he?
4 months.
4 months. Okay. What is his name?
Naim.
Naim. Okay. So Naim had rapid breathing at 8 o'clock last night.
Yeah.
So okay. Does the rapid breathing develop suddenly or is it gradual?
Just came to not out of nothing, just suddenly breathes fast. I don't know.
So it
what
occurred
to do, so
suddenly.
brought to us clinic first.
So you brought to the clinic. What was Naim doing at the time that he developed the rapid breathing?
We just going to sleep to after then to just lying there, then sleep time, then suddenly rapid breathing. You
So-
also have cough.
Can you increase your volume, please?
Okay, boleh dengar ke?
Yes.
Okay. What's the question?
So what was Naim doing at the time that he developed the rapid breathing?
Lying down, just going to sleep.
So he was lying down just he was just lying down and he developed the rapid breathing.
Yeah.
What do you think caused that rapid breathing? Is there any exacerbating or do you think that rapid breathing has any relieving factor?
Not sure, because there's they're coughing a few days before.
So he had cough for a few days before. How many days before actually?
2 days before rapid breathing, I guess.
So he had cough 2 days prior to rapid breathing and rapid breathing at 8 o'clock the night before. I would
Yeah.
like to ask a bit on the cough.
Okay.
Does the cough occur suddenly or is it gradually?
They just coughing occasionally, not all the time, but it doesn't becomes more often, so just intermittently.
So the cough just occurs intermittently. Do you think that there is any pattern of the cough? I'm sorry. So it just occurs occasionally. Do you think that there is any exacerbating factor for the cough, such as when the children was eating, or when he was playing, or is it just in random times?
I don't know, random, I guess.
Random. Do you notice any patterns to the cough, such as any, it sounds like barking cough, or any whooping, or if the cough is prolonged?
Just a short cough, like, but comes something.
So it's just short time cough. Okay. Does the cough, did you notice that the cough, does Naim had expectorated any sputum?
Yeah, about small amount lah, just small spoon, I guess.
Just small amount of the sputum. Okay, so what is the color of the sputum? Is it whitish?
It's yellowish.
It is yellowish. Did you notice any streaks of blood in the sputum?
No,
No, there's no. Does Naim had any any vomiting after he coughed?
no vomiting.
Not vomiting. Did you notice any change of voice in Naim's voice, such as
No.
it become hoarse?
No, just becomes normal after that. Just
Okay. Okay. So aside from the cough, did you notice that Naim has any other symptoms such as fever or
yeah. To also have fever, but just
also
warm.
have, since when did he have that fever?
Since start coughing.
So it is at the same time that he started coughing, he had that
Yeah.
fever.
Yeah.
Have you had, as for the fever, had you measured the temperature?
Just put hands on the forehead.
Oh, so you
You
just
don't
put,
have thermometer.
okay, so you just measure it by your hand. Okay. Okay. So did you notice that Naim has any chills and rigor during when he had that fever?
Chills and rigor. Oh, shivering. No.
Yes, sorry, shivering. No, okay. Did you give what did you do to relieve that fever? Did you give any medication, or did you do tepid sponging?
We just put a wet towel on top forehead. Tap sponging.
Okay, okay. Does Naim had any fitting episode during the fever?
No.
No.
No fitting episode.
Okay. So other than he had rapid breathing for 1 day and he had fever and cough. Other than that, did Naim had any other presentation?
Yeah, the runny nose.
Runny nose. For how long had he had that runny nose?
To the day before, the day after coughing start.
So the day after coughing start. So I'd like to confirm just now, the coughing is 2 days, right?
Yeah.
For 2 days, and then he had runny nose the day after. Okay. Can you describe about the runny nose? Can you describe a bit about the mucus? Is it the amount that came out? Is it a small amount or copious amount?
Small amount, just runny clear from the nose. We just wipe it off, then so it's not obstruct the breathing.
Okay, so it's just a small amount. Okay, so okay, I would like to ask a bit. Since Naim had this presentation, did you notice that he had that he become drowsy, less active, or lethargic?
Yeah, we compared to previous months, still a bit less active.
Previous months?
Yeah, during this month to compare to the less feeding, not playing around much.
Okay, so he become less active and also had less feeding. Naim is 4 months, so he is exclusively breastfeed, lah.
Yeah.
Okay. but he had less feeding. He had reduced feeding, but is there time that he refused to feed?
No, just macam mana, less crying for attention. But when feed, tries to put his mouse, feed by small mouse, then stop.
Okay, I see. Okay, so for aside from that, did you notice that Naim had any ear discharge?
Discharge, no, not
Is
that
there
big.
any change in the bowel habits, such as he had increased urination?
No, just
Did you
normal.
notice any rashes?
Where?
Uh, Anywhere on him?
No, none.
No. Okay, so he had cough, right? So did you notice that Naim had any night sweats, sweating profusely during the night?
No,
Is there
none.
any contact with patient, with TB patient?
No,
Okay, so had Naim had any history of water and soil contact?
water and soil contact. No, just she stays in the house.
Okay, all right. Okay, so since Naim had fever, cough, before he had rapid breathing, did you seek any treatment, such as going to the clinic or anything?
Not so much because it seems just coughing occasionally. No apa, not apa. Number fever is mild too, so we didn't take much of it.
Okay, so since he had this rapid breathing, did you notice that he had any nasal flaring?
Just nasal flaring, like then fast breathing faster or
Uh,
how?
did you notice that his nose, the his nose, his nose, uh, macam cakap tadi kan?
Expanding.
Oh,
Expanding.
a bit when started rapid breathing.
Okay, did you notice that he had any chest indrawing?
Chest drawing, no.
No. Okay, did you notice that he had any bluish discoloration of the lips during the episode of rapid
No,
breathing?
no,
No. Okay. So I would like to ask a bit about the past history. Does Naim has any known underlying medical illness, such as eczema, allergic rhinitis, or having any lung disease?
no, none.
Okay. Has he been hospitalized before?
Yeah, during to after birth for a bit.
After birth?
For yellow yellow apa? Jaundice, jaundice.
Yellowish for jaundice. For how since was okay. For how many days was that?
4 days, I guess, and
4 days. Is what was the management done for that?
management just UV, I guess. Lampu blue light.
Okay, so he was only under the blue light. All right. Okay. So there's also one thing that I forgot to ask just now. Is this the first presentation?
Of what? Rapid breathing?
Is this yes, including all of this, rapid breathing, fever, cough, is this the first time Naim had this presentation?
Yes, for him, yes.
Okay. Okay. So does Naim has any known allergy?
No, none.
No. So Naim is currently 4 months. So is he vaccination is up to the schedule?
Yeah. Last vaccination is 3 months.
At 3 months. Okay. Is there any complication post vaccination?
None.
None. All right. So I would like to ask a bit about the birth history. So do you have any underlying illness during the pregnancy, such as having any problems during the pregnancy?
During pregnancy, none.
None. Okay.
Uneventful.
How about the delivery? Yeah.
Uneventful.
Okay. So how about during the delivery?
At 37 months, by
37.
yeah, term.
Okay, 37 weeks by normal as week.
Yeah, normal delivery.
All right. Okay. So postnatally, he had jaundice, right? So he
Yeah.
was hospitalized.
Yeah.
All right. Other than that, is there any other complication?
None.
None. All right. Okay. So how many siblings does Naim have?
Two elder sisters.
Two elder siblings. So he's the third. All right.
Yeah.
Including you, your husband, and even the siblings, does any of you has any underlying disease such as asthma, eczema, or allergy rhinitis?
Nah.
Do you or your husband has any chronic illness such as diabetes, hypertension?
Nah.
No. May I ask how old are you and your husband?
22 and 27. Betul.
22 and 27. Do
23.
both of you work?
Itu apa? Plant, housewife and planter. Kebun.
Okay. So I'm sorry to ask, but do any of you smoke? No. Okay. So I want to ask a bit about your environment. Do you keep any pets at your house?
No.
Where do you live at?
Jalan tu.
Jirantut. Okay. So that's quite far. Okay. Uh, is there any, okay, so is there any at your house, around your house, is there any exposure to dust or dust mites?
No. It's
No.
not much traffic.
Okay. So I would like to briefly summarize. So Naim, the child is 4 months. So he had rapid bleeding for 1 day at 8 o'clock last night. But
Yeah.
prior to that, he had fever and cough for 2 days, right? The
Yeah.
cough was productive.
Yeah.
Okay. And he also had runny nose 1 day prior.
Need
Yeah.
the device to see not with the patient. Shahira,
Yeah?
Shahira,
Yes, doctor.
you will do summary for me, not for him. Okay.
Okay, sorry.
You need to do summary with me, not with Nasri.
Okay.
Can you
So
do summary for your case, please?
for my case, okay. So Naim, a 4-month-old boy, presented with rapid breathing for 1 day. So it was associated with fever and productive cough for 2 days and runny nose for 1 day. There was also reduced oral intake, and there's one thing that I forgot to ask. Sorry, is there any sick contact?
Sister tu apa? There's coughing similar, the coughing fever the day before, but resolved to 3 days ago.
So the sister had cough and fever. But
Since 1 week ago, then stopped after 3 days ago.
then start after 3 days ago. Okay. So only one sister aside from that. Is there any other who had the
No,
same symptom?
the other siblings are okay. Me, parents okay. No coughing.
Okay. So the child is with you. Is there any caretaker?
No, just taking care at home. One of the
Okay.
parents.
Okay. So I would like to redo my summary again. So Naim, a 4-month-old boy, he presented with rapid breathing for 1 day duration. It was associated with fever and productive cough of 2 days and runny nose for 1 day. There was reduced oral intake and there was also history of sick contact with the sister.
Hello.
Hello, I think that's all. Hello, can you hear me?
Hello.
Yes, doctor.
Again, believe looks like the line is interrupted. Can you do summary? Summary, please.
Okay, so summary. So Naim, a 4-month-old boy, presented with rapid breathing for 1 day. It was associated with fever and productive cough of 2 days and runny nose for 1 day. He had reduced oral intake and there was history of sick contact with his sister.
Any other positive points from the history? Please, everyone need to mute his microphone, please, other than the one who is speaking. Yes, Shahira?
There was no family history of asthma,
Okay.
family history of atopy, and this is the first presentation.
Okay. So what's your working diagnosis?
So my working diagnosis is actually the first one is pneumonia because this patient had fever and he also had productive cough and fever, productive cough, runny nose, rapid breathing. So that is my first my first diagnosis. Then, however, my provisional is bronchiolitis, firstly because of the age. He is 4 months. But however, this patient had productive cough, so it is a negative points of the bronchiolitis.
Anything else? Any other diagnosis?
Other diagnosis, I think less likely, but it could be pulmonary TB because this patient had cough, but there is no history of contact with TB patient and the cough is acute. It's not chronic and there is no night sweats. And other than that, I would think of also croup, but also I think less likely because there is no hoarseness of voice, but this patient had cough and fever.
Other? Okay, let us go for diagnosis of bronchiolitis. What is the causative organism?
For bronchiolitis, the positive organism is by RSV, respiratory syncytial virus.
Okay, how can you diagnose it, the investigation?
Investigation to diagnose bronchiolitis, doctor.
Yes.
Okay. So as for the bronchiolitis itself, it is clinical, but on investigation, what we can do is we can do spirometry to look for the severity of the bronchiolitis itself, to look for the oxygen saturation, and other than that, we can do chest X-ray to look for if there is any hyperinflation of the chest. And
Okay, any other investigation you can do for bronchiolitis?
PCR, doctor, to confirm that the causative organism is RSV.
Go to the note.
Swab.
Who is speaking? There is someone speaking. Why you are not all of you muting your microphone?
I'm sorry, doctor. I think it is from my house.
Your side? Okay, you are welcome. No problem. We can negotiate with you. So it is very important to know that there is something known as RBP. What is the RBP? Respiratory panel. respiratory panel. It is just the same which you are doing the COVID or anyone. We are just doing nasal swab for RSV. It's very simple. We can do it for like influenza, for RSV, and sometimes you can make a big panel which can give us about 30 virus and some atypical bacteria. Okay. When did you suspect atypical bacteria in this age?
I think it went from physical examination.
It is pneumonia. What else?
I'm sorry, I'm not sure about that.
Who can answer atypical pneumonia in small babies? Anyone can answer, or should I ask? Azika?
For atypical,
Yes.
patient might have prolonged fever or prolonged fever, I think.
So what is the difference between typical and atypical then? Okay, what is the organism do you know that it can cause atypical?
Mycoplasma pneumonia.
Good, very good. Mycoplasma pneumonia, usually it will occur for the school age children or preschool. But there is one unique organism for the atypical for early infancy.
Chlamydia, trachomatis.
Yes, yes, this is a very important. Not to miss chlamydia pneumonia, which usually came from the mother side if the mother has chlamydia. Okay, appear within 3 months, like that, early infancy. And there is an important point, which is the child usually got conjunctivitis. Okay. Hello.
Okay.
Yes, sir.
Can you hear me?
Yes.
Yes.
So you must, at this small age, rule out the atypical. And you must know that the atypical has chest X-ray, which you need to read. Sometimes you will find the baby is very symptomatic and the reverse X-ray is not so bad. And sometimes the baby is not so symptomatic and the X-ray looks bad than the baby. Shahira need to answer that for me after. Okay. So if you ask Hamiza, what is the treatment of atypical microbe?
Antibiotic.
Sorry?
Hello? Hello?
Yes, Hamiza. Yes. What is the treatment of atypical?
Antibiotic. Hello?
Yes, of course. What type of antibiotic?
Type of antibiotic.
Which antibiotic you are going to give? Atypical.
Microlide.
Yes. Okay, why you didn't give her a chance? Yeah, that's why if you find any child usually in severe pneumonia until waiting for the lab result, we are in the pediatric protocol, you can find you are going to use like third generation cephalosporins and macrolide, like erythromycin, azithromycin. It is very important. Okay. Let us ask the CT is a tool. If you did chest X-ray now, how can you differentiate between different pathology by the chest X-ray?
If it is pneumonia, then there will be a consolidation.
Okay, consolidation can be also consolidation collapse. Can be what else? Can be any complication of the pneumonia.
Can be parapneumonic effusion.
Okay, so pleural effusion. So we must suspect either the diagnosis itself or its complication. Okay, for bronchiolitis.
Not sure, doctor.
Okay,
Hyperinflated.
Hyperinflation.
yeah, hyperinflation, but sometimes bronchiolitis also can cause the same characteristic of pneumonia. Even if you read your pediatric protocol, sometimes it can cause some like infiltration and even some consolidation collapse, which is not stringent. But the blood investigation will guide us. Is it severe bronchiolitis or maybe viral pneumonia? Okay. So Hafifi, what is the difference between lobar and bronchopneumonia?
Sorry, the question is about the lobar and also the bronchopneumonia into X-ray.
How can you differentiate?
Clinically or X-ray?
If I give you open question, it's your chance to start.
Okay, so basically the bronchopneumonia is usually on X-ray we can see generalized consolidation or infiltration on X-ray, but in lobar pneumonia we can see usually in lobar consolidation.
In one side is, do you know what is the organism which can cause everyone? Lobar or broncho?
Usually the bronchopneumonia caused by the viral, and the lobar pneumonia usually the bacteria. So in infant can be GBS or also chlamydia.
If not infant, preschool?
Preschool strep pneumonia.
Other organisms. So we need to revise the organism, both lobar and the broncho.
Staph aureus.
Yeah, must rule out staph. Okay, let's go for the OSCE and the differential diagnosis part. Sorry, Shahira. Shahira?
Yes, doctor. Yes, doctor. Hello.
It's very important for us. This is an important lesson for all of us. Don't use close questions for an important point in the history. Like vaccination. Vaccination now we are faced by some people who is trying to be anti-vaccine. So if I ask you like you did, what about vaccination? Is it up to date or up to the schedule? Said yes, done already. Yes or no, I don't know unless the book is in my hands. But at the time, it's better to ask him open question. What about the vaccination? When is the last time did you give him the vaccination? Okay, so at that point you may catch if the patient is regular. What about the BCG in your case? You are speaking about TB. What about the BCG? Is there any scar on its site or not? So it is very important, please try to deal with the community with a good concept set that we can pick any deviation from normal easily, okay? So it's better to start by open and then go for closed after that. Thank you. Okay, now differential diagnosis by whom? Who will present the differential diagnosis?
Me, doctor. For the differential diagnosis, first we suspect that the patient might have pneumonia because, as mentioned, the patient have productive cough. Can you hear me? Hello? Hello?
Boleh dengar tapi macam ada background sound. Bunyi angin.
Okay, go ahead and let's.
Okay. For the differential diagnosis, first I'll suspect pneumonia because patient have productive cough. Also, patient also have fever, rapid breathing, and poor feeding. And not to mention, patient also have history of sick contact. However, bronchiolitis can also be the differential because patient also presented with fever and runny nose, and also rapid breathing. However, because the productive cough are more towards pneumonia, so it sit below pneumonia. Other is upper respiratory tract infection such as pharyngitis because patient have fever, history of sick contact, and also runny nose. However, there's no productive points against because usually upper respiratory tract is caused by viral, so usually patient don't have cough, and there's no lymphadenopathy. Other differential diagnosis can be croup, since patient have fever and runny nose, coryza, but because the parent did not mention that the patient have barking cough, so it is point against, and patient also don't have stridor, which are likely to diagnose for croup. Other differential can also be foreign body inhalation because foreign body inhalation can also cause cough and fever, also poor feeding, but it is against because there's no history of vomiting and noisy breathing such as stridor. For pulmonary, other also can include is pulmonary TB because there's history of poor feeding. However, it is mentioned that there's no history of contact with TB patient. There's no loss of weight, and the fever and cough is acute setting, which is less likely to be pulmonary TB. We could also include pertussis because of the presence of cough and rapid breathing with poor feeding, but because of it is mentioned there's no whooping cough and patient is not sinus and the patient is vaccinated, so it is less likely to be pertussis. That's all for the differential diagnosis.
If you are doing full blood count.
Full blood count?
Yeah, what is that?
What is the finding?
Yes.
for full blood count, we usually look for the white cell count to identify whether there is an infection, and we can look for the differential, whether it is lymphocyte or neutrophil. If rise in neutrophil, usually it is bacterial in origin. If it is neutrophil, most likely it is viral.
Yeah. Usually, besides history of vaccination, given or not, it is very important. Okay. The issue is there is absolute lymphopenia. You'll find the leukocytosis, but with about 90% and above are lymphocytes. So if you find that, take care, please, about that. Okay. Of course, we must define the cough to acute and chronic. So our differential diagnosis for acute cough is different from the chronic one. So the chronic one can be TB, can be cystic fibrosis, another like severe persistent asthma. So you must be able to put in your differential diagnosis to divide into two areas, okay? Okay, let's go for the OSCE.
Alia?
Hello, can you hear me?
Yes, yes.
Yes, yes.
Okay. Okay, sorry. So okay. So for OSCE, I have prepared 5 questions. So question 1. A 2-year-old boy was brought by his parents to breathing for 2 days. So, then what further history you would like to add other than what shown in the picture, which is drawing. So, anyone would like would want to volunteer to ask to answer?
Maybe I can try.
We
Okay, so for the differential diagnosis, so because this is an acute cases, so I would think of pneumonia because of present of fever, and also acute bronchiolitis, and also due to foreign body inhalation because this is acute cases and toddler, and also maybe viral induced risk. So for further history, I would like to ask according to the diagnosis. So if it is pneumonia, so we ask present of cough with sputum, and then fever, high-grade fever, and then any history of sick contact at home or even at the nursery where the patient is taken care of. And then so for acute bronchiolitis, also history of URTI, and also a history of sick contact. And then for foreign body inhalation, maybe could ask the parents of the patient any history of witness see the patient any foreign body inhalation. And then for viral induced risk, apart from the difficulty in breathing, is there any cough or noisy breathing? So for what are the sign of respiratory distress? So from top, is there any nasopharynx, and then cyanosis, noisy breathing such as grunting or grunting, and then any use of accessory muscle, any intercostalization. Yeah.
What else?
Tachypneic,
Okay, what else?
any recession intercostal or supraclavicular.
Okay, better to start from the nose. What you can see in the nose.
Nasal flaring,
And
and noisy grunting.
grunting are very important. So if we start from up, it will be nasal flaring and grunting. If we come down, must take care about cyanosis, which is the most serious one. Now for recession, either supraclavicular, intercostal, subcostal, and tachycardia is very important. And then the vital signs, because if the child has severe distress, we'll find now the heart rate also like that. Okay. So I would like to ask someone question about Zain.
Yes, doctor.
If you put your stethoscope on the chest of this child, can you tell me your findings?
So,
He has pneumonia.
okay. So the findings of this patient would be first reduce air entry, and then there will be cost crepitation.
Before that, we spoke together. Before that, we must have a flow. So there is decreased air entry. Then, after the air entry, before you jump to the added sounds, you will comment on. I am speaking about auscultation, the flow for auscultation.
Oh,
Bronchial sound?
Yes, this is very important. A, B, don't forget A, B. So number one, number A is the air entry, B is the breath sound. What did you suspect the breath sound to be?
bronchial sound, bronchial breathing.
You must be able to differentiate between the different type of air entry, which is either alveolar or bronchial. And even if you come to the crepitation, you must be able to differentiate between different severities of or different type of crepitation. It is fine or moderate or like that, okay? Good, let's go for the second one, for the second question.
Okay, so next, the second question. 1-year-old girl was presented to emergency department in view of high-grade fever, productive cough, and rapid breathing for 1 day. Upon auscultation, generalized crepitation was heard. Chest X-ray revealed generalized patchy consolidation of both lungs. So first one, what is your provisional diagnosis? The second one is what the common etiology of based on your diagnosis, and list the 3 investigation. Okay, anyone would like to try?
Can I try?
Yes.
Okay, so my provisional diagnosis according to this presentation is bronchopneumonia, because patient have high-grade fever, and then the patient have cough and rapid breathing, and also patient have generalized crepitation and generalized patchy consolidation. So that differentiate between bronchopneumonia and also lobar pneumonia. And then the common etiology, I believe we have discussed the etiology just now. So it is according to the age, right? So for newborns, group B Streptococcus, E. coli, and Klebsiella. And then as doctor mentioned, usually we must also think about chlamydia trachomatis, especially in infants. And then for preschool age, such as Streptococcus pneumoniae, Haemophilus influenza, and also Staph aureus. And then for school age, Mycoplasma pneumonia and also chlamydia, which are the atypical cause. So that is for the etiology. And then three investigations that I would do. First of all, I think it is important for us um, to check for um, his sputum, and then do sputum culture uh, and sensitivity. And then next is full blood count to look at the white cell, especially to look at the white cell counts to differentiate between bacterial and also um, viral causes, which is look at the neutrophils and also lymphocytes, which one is predominant. And then next is, since patient have high grade fever, so I want to rule out bacteremia, so I would like to do blood culture and sensitivity.
So it is very important for us to remember again and again the bedside test for most of the respiratory cases include Aslan.
Yes, doctor.
The
So
bedside
for
test.
the bedside test, I will check pulse oximetry.
Okay. What else?
Then sputum culture and sensitivity, and then what else?
Who can add?
Okay.
I used to tell you, take care about bedside tests. Number one, he said this is the pulse oximeter. Okay. What is number two? It is the same place. This is the radial artery. Why? To do blood gas. Because any organ you are examining, if you didn't put in your mind if this organ are failing or not, you will miss it. Respiratory failure, how many types do you know?
Two types.
Two
Two
types.
types.
All of you now can speak, but how can we rule it clinically or investigation-wise? So number one, pulse oximeter. Number two is arterial blood gas, which is ideal. If not, we can try to interpret the capillary or venous. The last one is the same together, which is the peak expiratory flow rate if the child is more than 5 years. Okay, so please, in each case, try to ask yourself before many times I'm speaking with you, what is the lab, what is the red, what is the bedside test, and at the end, what is the specific test for this case? Okay, continue, because we need to shift to the second case for tight time with Gumaat. Okay, good.
Okay, so next question. 8-year-old boy presented with fever and cough for 1 week. Investigation revealed raised white blood cell. Chest X-ray was performed. So first one, describe the chest X-ray finding. The second one is what is your provisional diagnosis, and the third one, 2 complications that may arise from this condition. Okay. Anyone would like to try?
Hello, can you hear me?
Yes.
So I would like to try to answer this question. So first, describe the chest X-ray. From the chest X-ray, we can see that there's a opacity at the left lower zone with a perihilar haziness. And then there was no tracheal deviation, and the costopharyngeal angle is also can be seen. And then my provisional diagnosis, I think it is a pneumonia, and the two complications that may arise from this condition, which is pneumonia, it could be parapneumonia effusion, empyema, lung abscess, or it can also occur. Pleural effusion also can occur.
Okay. I would like to come back to the chest X-ray. If you find this chest X-ray now with this pneumonia, you found the heart are very, very big, about 2/3 or more of the chest. What's your diagnosis?
EOR.
What is EOR?
Tetralogy of Fallot. Sorry.
No, before he has normal X-ray. You are waiting for 8 years to diagnose tetralogy of Fallot. Okay, no issue. He has normal chest X-ray before, but he got pneumonia, and then we found the heart are very big. What can be the diagnosis? It is very important. Viral myocarditis. It occurs sometimes as a complication of viral. We know that it is viral and it is the most common cause, but sometimes it is accompanied by viral myocarditis, which you will find the heart known as
Hello? Hello?
Doktor mana? Left ke?
Internet kot.
Doktor dah left.
okay. Sorry, I am trying to avoid using the mobile because I'm on call. No issue. If they call me, I will interrupt it also because the hospital internet is not so okay. Did you understand my point now? Very, very important not to forget that the heart and the lung looks like two organs together can be sometimes presented by the same issue. Can we come to the next, Oski?
Okay. So the next question. Chest X-ray was taken in a 2-month-old infant presented with respiratory distress preceded with mild upper respiratory tract infection symptoms and low-grade fever. So based on this X-ray, describe your finding. What is your provisional diagnosis and 2 complications that may arise from this condition? Okay, anyone would like to try to answer this question?
I would like to try. Okay, so A, describe your finding based on this chest X-ray. We can see it is a chest X-ray of a child with hyperinflated lung
it is seem that the ribs are flattened and okay, I think that's all. And for provisional diagnosis, usually for hyperinflated lung, we suspected would be bronchiolitis in children. For the two complications that might arise from bronchiolitis, the child might be get a secondary infection or can persist to respiratory failure such as apnea.
What other common complication?
The common complication will be usually the common complication for bronchiolitis will be aspiration pneumonia or secondary and it might that's the secondary infection and also
It can occur, but the most common.
the most common
Bronchiolitis.
Is it respiratory failure, doctor?
Yes, respiratory failure, we said it can occur either type 1 or type 2, but it's very common to find him dehydrated. Why?
The common finding?
It is commonly to find him dehydrated. Can you tell me why he became dehydrated?
I think because the respiratory distress cause okay, jap. Is it cause
Decrease oral intake. Yes. If someone is distressed, he cannot go normal for his food or for his breastfeed, and at the same time, he has tachypnea, which make him also lose a lot of humidified and like that with the breathing. For all this can settle him with some degree of dehydration. So take care, please. At this point, we must assess the dehydration state of the child, okay, which is very important.
Okay, thank you, doctor.
Welcome.
Okay, so we proceed to the last question for the first case. So a 5-year-old girl went to a general practitioner and diagnosed as community acquired pneumonia and discharged with antibiotic. However, after completing the antibiotic, the symptoms do not resolve. So the first question, what are the criteria for hospital admission? And can you discuss what is in the inpatient management? Anyone would like to try? Or Shah, can you answer?
Hello, can I try? Answer? Okay,
Yes.
Okay, so first question, what are the criteria for an hospital admission for this 5-year-old girl? So first, I think it's for children aged 3 months and below, and then if the patient has fever, high grade fever or non-nasal fever, and then poor feeding or oral intake, and then if the patient have any fast breathing with cyanosis or without cyanosis, and then any systemic other manifestation that is alarming, and then if this patient antibiotic therapy or in case of recurrent pneumonia. And then for second question, for infection management. So first, we need to monitor the vital signs of this patient, especially the respiratory rate. And then we need to monitor if there's any signs of respiratory distress, as mentioned earlier, start from the nose like nasal flaring, grunting, cyanosis, intercostal recession. And then we can start this patient on antibiotic, augmentin, and then we should give other supportive therapy like fluid, oxygen, mask for oxygen therapy.
What's your comment, the one who did the OSCE? Can I see your answers? What is this? Is it the answer?
Me, Dr. Alia.
No, the answer for the last question.
Plus.
Can you come back to the question itself? It is 5 years old. What is the answer of this one?
You mean the second question, inpatient management?
No, the 5 year. You said children aged 3 months and below. This is.
Oh, also the first one is just a general indication for at any age which presented with pneumonia, but severe pneumonia or unresolved pneumonia. So these are the criteria for hospital admission.
I see. It is very important for us to do two important things in our practice. Soon you are going to start your practice. It is what is the criteria for admission and the criteria for discharge. And the third point, what is the discharge plan for every patient? Okay, is it clear? Criteria for admission, criteria for discharge, and the most important is the plan upon discharge. Number two, if we come to this, to the question side, we must comment about the very important, the choosing of antibiotics, especially if the child finished before. Can you come back with the question itself? What is the antibiotic was given before?
I think amoxicillin.
So at that moment, we must do investigation to rule out other organisms, but we must suspect atypical because this is the school age or preschool age. Usually, if not responsive within 48 hours to 72 hours to amoxicillin, we must suspect the atypical one. So I think I am going to go for the second line. If you open your also pediatric protocol, you'll find the first line, which is amoxicillin or amoxicillin clavulanic acid. Second line, it will be cephalosporin, either second or third, according to the severity, plus macrolides. Okay? So it is very important to consider that. The last comment before closing the session of this case, no one of you touched the issue of asthma and viral induced asthma, especially if this patient has some wheezes. We must take care about that, and we must be able to discuss the asthma and what is the criteria for diagnosis of asthma and what is the asthma predictive index and how is the guideline for asthma, okay, for upgrading or downgrading our care. It is very important, please. Okay. Good. Let's go now for the second case, which we hope at 12:30, inshallah, we are going to stop our session for Gumat.
So So, Assalamualaikum warahmatullahi wabarakatuh. So, for second case, I will be the doctor while Farahiza will be the parents of the children. Okay, children, Farah.
Can you hear me?
Yes.
Okay, so I will be the parents. I mean the mother.
Okay.
Okay, so, I'll just wait for you soon.
So, Assalamualaikum warahmatullahi wabarakatuh. May I know your name, Mrs.
Miss Amira.
Miss Amira. So, what is this child name?
His name is Ahmed.
Ahmad. So, Ahmad, may I know his age?
He's 9-year-old.
9-year-old.
Yes.
So, may I know why did you send him to today?
Actually, he's been vomiting for 5 days already, so I was quite worried about his condition.
Since when? 5 days ago, is it?
Yes, he been vomiting for 5 days.
Is it sudden or gradual?
Uh, it was sad. I would say the first time he vomit after he had his meal, to like 2 hours after he had his meal. But more recent, like 2 days ago, even though he eat a little food, he vomit right away. So does that answer the question?
Yeah. I would want to know, does it have anything to do with eating? I mean, what if the child does not eat anything? Does the child still having vomiting?
He can't really eat because he say he do not have any appetite to eat. But I think he has no problem in eating because if he has the appetite, he can eat the porridge.
Okay. If the child does not eat anything, does the child still have vomiting?
Yes, because even even after like like I say like a few hours after eating, he still vomit.
Okay, I see. So, does is it projectile or not?
Projectile. I think it's not. I'm not sure. Sorry, doctor.
It's okay. So how much does the child vomit?
Initially he only vomit once, like twice in the like starting on the first day, but recently he vomit until like 5 times per day, quite a lot also.
Now 5 times per day.
Like one day before, like yesterday.
Okay, I see. So and then how much does the child vomiting per vomitus?
It's quite a lot. I think it's around like one bowl or one, how do you call it, one glass.
Okay, so may I know the content of the vomiting?
It come out food, and then a little bit watery. Food content. I would say food content. Depends on what you eat.
I see. So food content, is it have digested or not?
Mm, but the one he vomit right after haven't digested yet lah. But some of it already digested.
I see. Okay. So basically it is food particles.
Yes.
So does it contain blood?
Oh no, no blood.
How about greenish content?
Greenish. I didn't notice any greenish. Because he don't eat vegetable also. But I don't know.
Okay. Okay. How about fecal materials?
Fecal material. Oh, you mean like feces, doctor?
Yes.
I didn't notice any fecal material.
Okay. And then does it if that is it associated with motion such as funfair riding or boat riding?
No, he did not have that problem.
So previously also patient does not have motion sickness, is it?
No, it's okay.
So is this the first presentation?
The vomiting?
Yes, the vomiting.
Yes, you can say that.
Okay. So first presentation and then since 5 days ago lah.
Yes.
Okay. And then does the patient takes any drug? Medication. I mean medication.
No, he didn't take any medication.
Before the vomiting also does not take any medication?
But actually, he had fever, like prior the vomiting.
Okay.
Like 2 weeks prior the vomiting, he had fever. We did go to the clinic and then given paracetamol. But I think that's all.
Okay, so let me finish the vomiting first. So does the child take any outside food?
We did go to a restaurant, like but it's a usual restaurant. And the rest of family did not have any problem.
Oh. So history of eating outside is before the vomiting started, is it?
Yes.
How days before?
It is, I would say, around quite only 2 weeks before the vomiting.
Already
Yeah.
2 weeks before. Okay, I see.
Yes.
So that's the last time the child eating outside lah.
Yes.
Okay. So does it associated with diarrhea?
He had diarrhea, but only once, like
Only
2 days.
2 days before? What?
2 days before I come here.
Oh, okay. So just once. Just once. Okay. So how much does the patient have the diarrhea?
The patient had how much? I think it's quite a lot because he quite long in the toilet. But how we say how much?
How frequent is it?
How frequent? It is only for 1 day. And then frequent. He went back and forth. I would say like 5 times, 4 to 5 times to the toilet. I accompanied him to the toilet.
I'm sorry. Is it 5 times?
Yes.
Okay, 5 times during that particular day lah. Is it?
Yes.
Okay, so 5 times during just that one day.
Yes.
Okay, so is like echoing. So, and then does the patient does the child can take orally, tolerate orally?
No, he cannot. He had he lost appetite.
Okay, so the child have trouble eating orally lah. And then does the child feel thirsty all the time?
Does the child
Okay, does the child feel thirst all the time?
He he does seem dehydrated, but he thirsty. I would say yes because he do feel thirsty, but you know when he want to drink, he has the nausea and then wanted to vomit.
Oh, okay. So does the child cry?
During the vomiting, yes, he sometimes cry.
Okay, how about the tears?
The tears, yeah, the tears, there's tears, doctor.
I'm sorry?
There's tears.
There's tears, okay. How about the urine of the child?
The urine, I noticed the child have, he say he had painful urination during, before the vomiting started, but I do not remember when, but he say it was painful urination.
Okay. How about the volume of the urine?
The volume was okay, I would say.
How about the concentration of the urine?
Concentration, a little
In
bit.
color?
The color is quite like darker in color than usual.
Okay. So then you mentioned that the child. Okay, sorry. So how about the dietary habit of the patient?
He eats well, but when he started the symptom, he started to be sick. He cannot really eat.
Okay. Usually, what is the frequency of the child?
He ate quite a lot. Like in one day he had breakfast, like even nasi lemak, and then in the evening he will eat again nasi, and then also at evening some snack, and then at night I would say previously he eats well.
Okay. How about now? How about
Now
after the vomiting?
it's quite hard because he probably only eat like only twice a day. That's we try to make him eat like porridge.
Okay. Does the child have any food allergy?
No.
And then does the child consume any milk?
Consume any milk? Consume any milk? For right now, no. He already stopped drinking milk.
Oh, okay. So when was the last time he drank milk?
I would say 1 year, like since he's 1 year old.
Oh, okay, I see. So since 1 year old, and then he does not consume any milk until now, is it?
Yes.
All right. So you did mention about fever, right? 2 weeks
Yes.
ago. So how about the fever? Can you tell me more about the fever?
The fever, uh, it only lasts for around 2 days, but
Okay.
I would say I want to tell you, doctor, the fever he also during at the time of the fever he also had rashes all
I
over
see.
his body. So but the rashes already dissolved. I think only for around 5 days at the same time with the fever. And then
Okay.
2 weeks prior the vomiting started.
Okay. So I noted that the child has fever, but let us finish. It also has rest, but let us finish about the fever first. So you mentioned the duration is 2 days, right? And then the child have given paracetamol. So does it resolve with paracetamol?
Yes, I would say it resolved with paracetamol.
And then do you know what is the temperature during that time?
Sorry, doctor, I don't remember.
Oh, so
But I
how
would say quite high.
about what? About 38, 39, 40?
I think it's 30, I would say around 39.
Oh, around 39. Okay. And then so the fever already resolved lah. So during that fever, does the child have any um any cough,
No, no count.
sore throat?
Mm, Sulfur, I don't think I use sulfur.
Any runny nose or sneezing?
Runny nose, no.
Oh,
No runny
during,
nose.
okay. During that time, does the patient have any diarrhea and vomiting also?
No, no.
Okay.
During that time, not yet.
All right. So about the rashes, you mentioned it is 5 days, right?
Hmm.
Does the patient have any sick contact?
Uh, Actually, at his school, there's also another classmate who had the same rashes.
I
But
see. So is it completely resolved now?
for Ahmad, yes, he no longer have the rashes.
I see. Okay.
But the rashes already like turned crust.
So did you remember what type of rash was that?
2 to 3 minutes.
The rash was red, and
Red?
then there was
Say
Yeah.
2 to 3 minutes.
Okay, doctor. Noted. Okay, what
the
type of
rash was
rash?
red. The rash was red. There was redness, and then also there was also I would say macam that race, and then it come out clear fluid, and then started to become crusted like after on the 5th day.
Okay. Does the child take any medication for the rashes or any topical medication?
We give him lotion, and then like frequent bathing.
Okay. So no any not taken any antibiotics and antiviral?
No, we didn't give because we expect get well, and because we see the rash gone, so he become healthy. So
Okay. Okay, I see. Okay, now does the patient have any headache?
yes, he do complain of headache. Like he say very painful the headache.
Very painful.
Mm.
What is the pain score of the headache?
Mm, the pain score I say very painful. You see I have to ask. We say sometimes cannot sleep at night lah.
Oh. And then so the headache started when?
The headache, during the same after the vomiting, I would say 4 days.
Okay, I see. Okay. So and then how about any neck stiffness?
Neck stiffness,
Yes.
neck
Or
stiffness.
pain at the neck?
He didn't really complain of neck stiffness, but he did complain like he cannot really like when light he cannot really open his eyes when there's like very bright light.
Oh, I see. Okay. So does the child have any weakness?
No, he did not complain weakness, but he complained very fatigue due to a lot of vomiting.
Okay. So does the child also have fatigue and lethargy lah?
Sorry,
And then, so the child have fatigue and lethargy.
Yes.
Okay. So does the child have any numbness?
Numbness, he didn't complain. He didn't complain any numbness.
Does the child have any seizure?
No, no seizure.
Does the child have any facial asymmetry?
No, no facial asymmetry that I noticed.
Okay. Does the child can walk normally?
No, he did not have he cannot really walk. He didn't have the energy to walk.
Oh, okay. Due to lethargy, is it?
Yes.
Or is it okay, the child does not have weakness, right? Okay, how about talking? Does the child can talk normally, or if there is any slurred speech?
Mm, mm, he do. I didn't notice.
Okay. So how about does the child have any loss of weight?
Yes, he do have lots of weight. I would say around 4 kg.
Around 4 kg. So what is the child weight right now?
Previously he was 45. Now he's 40 kg.
Okay, that is for 5 days, is it? 4 kg loss for 5 days?
No, actually we did not notice when he lost the weight, but we did try to weigh him like recently. He already lost the 5 kg.
Okay, so 45 kg, when was the last time? When was it the child weigh 45 kg?
I would say around 1 to 2 weeks ago.
Okay. And then if the child have any trauma to the head?
No, no trauma.
So does the child have any previously hospitalized?
No.
And any known medical illness?
No, he did not. He was healthy previously.
Okay, this is the first
Okay.
hospitalization, is it?
Okay, then.
Okay. Okay, so.
Yeah, Zain.
Yes.
Can
Yes,
you
doctor?
summarize now?
I'm sorry?
You are now very. Can you summarize? You summarize now, please.
Oh, okay. So this patient, Ahmad, a 9-year-old boy, Malay boy, presented with 5 days of vomiting, and also have photophobia and also headache. And upon further history taking, the mother also complained of previous history of fever and also rashes 2 weeks prior vomiting. So that is their summary. So my provisional diagnosis is varicella zoster meningitis, because the rash could be due to previous chickenpox or varicella zoster infection. And the patient also presented with symptoms of meningitis such as vomiting and severe headache, so for my differential diagnosis is acute gastroenteritis, food poisoning, food allergy, lactose intolerance, but the patient does not take any milk, and then any obstructive causes such as pyloric stenosis, but the child is already 11 years old, so less likely. And then tumor of the GIT, but then again, the patient is only 9 years old, so it is quite young to have tumor of the GIT. And then other neurological causes, I'm thinking about space occupying lesions such as brain abscess and also brain tumor. But then again, for brain abscess, the patient does not have any fever right now. And then other meningitis such as bacterial causes, but I would like to confirm it with CSF analysis and also blood culture, and also other meningitis such as poliovirus and mumps, but I didn't have the time to ask about vaccination history. So that's all for provisional diagnosis and also differential diagnosis.
If you did CSF, what you will find?
I'm sorry, doctor?
If you do lumbar puncture, what is the findings of CSF?
For viral meningitis, is it? Okay, so for viral meningitis, first of all, for the appearance would be clear, and then there will be elevated white cell count, especially lymphocytes. And then the glucose could be normal. And then for protein, usually it is elevated in viral meningitis.
So how can you differentiate between meningitis and encephalitis?
I'm not sure, doctor.
Who can answer?
Yes, Aslan?
I'm sorry, what's the question again?
The difference between meningitis and encephalitis. How can we differentiate between meningitis and encephalitis?
Basically, from the history, I think we can ask if there is uncontrollable cry, changes in mental status, changes in behavior, for example, more to suggestive of encephalitis.
So according to the history, what's your diagnosis now? Your patient has photophobia.
Yes. So is that
So
the
you need
sign
to
of
revise your
encephalitis? So a varicella zoster encephalitis.
Yes, you must. Yes, you must suspect that, which is very important. From the
Okay.
clinical signs, any behavioral or any photophobia, changing behavior, all this is a clue for encephalitis. Okay.
Okay, doctor.
It will occur with viral. So you must suspect, is it viral meningoencephalitis or not, which is very important. What is the management here if you suspect it is varicella zoster meningoencephalitis? Because sometimes the varicella zoster can come just with acute ataxia cerebralitis, and it looks benign. But if it looks like signs of meningoencephalitis, how can you treat it? Okay, we are asking for help.
I think the management is supportive management. So for if there is any fever, we give antipyretics. And I'm not I'm not really sure, doctor.
So yeah, if you don't know, said don't know in medicine, you must be very clear. Who can answer? City is a tool, you have focus for that.
What's the question again?
What is the treatment of varicella zoster encephalitis or meningoencephalitis?
Maybe the first thing is to secure the ABC, the airway breathing and circulation, and then give antiviral.
Yes, so it is very important at this situation. If you have a mixed picture of meningoencephalitis, you are going to start by the third generation cephalosporin and acyclovir. Okay, until you confirm the final diagnosis and the culture of the. An important point here: how can you rule out CNS problem? زي like increase intracerebral pressure.
What was the question again, doctor?
ICP.
Oh,
intracerebral.
So the question was
Yes.
how to exclude increase in ICP, is it? Okay, so the answer is
how can you diagnose and treat?
First of all, symptoms. So for symptoms, usually have a really painful headache, and then the patient will also have a projectile vomiting. And then other than that, I think, is it Cushing triad for increased ICP, is it?
You just answer. Are you asking
Okay.
me?
Okay, so and then for Cushing's triad, so there will be increase in blood pressure, but have bradycardia and also bradypnea. So that is for Cushing's triad, and then after that, we must do CT scan to confirm there is no space occupied lesion in the brain.
Any other diagnostic issue in your hand? More, yeah, we are waiting for the CTs. They tell you it's tomorrow.
Endoscopy.
Yes, fundoscopy are very important to looking for
papilla edema.
important criteria for diagnosis of intracerebral pressure is the papillary edema. Okay, so just fundoscopy can tell you if there is increased intracranial pressure until you confirm by the CT. Can you hear me?
Yes, doctor.
Hello?
Yes, can
It's
hear.
very important to know. It's very important to know what is
So, doktor cakap tadi kena buat fundoscopy for papilledema. Okay.
you must revise the
Sorry, doctor, we cannot hear you. Doctor?
Aku dengar you must revise the
slide about
Doctor?
Doctor? Doctor, are you there?
Can you hear me?
Yes.
Yes.
We can hear you. Now.
I need for you to prepare an important slide about the red flag or flag signs of increased intracerebral pressure. You mustn't miss it. When is the type of the pain, when it will appear, what is the relation with walking, what's the relation with eating, with vomiting, okay? Any diplopia, any all this, and don't forget the papillary edema checkup. It is in your hand and easy to be done by simple fundoscopy, okay? Also, don't forget the other problem in the body, which can be UTI. UTI in childhood can be precipitated by vomiting. Also, otitis media. I know that it usually occurs and earlier than that, but you must rule it in case of vomiting. Okay. Vomiting is a very wide, important sign. She can indicate even surgical causes. You must put it closed one. I would like to rule out surgical causes. It may be we have intestinal obstruction, we have another problem like that, okay? Can we proceed for the OSCE, please?
Okay, can you hear me? Okay, so we proceed with the OSCE. So first question. Next. Okay, so question 1. Okay, first state the causative organism of meningitis in unit, baby with 1 to 3 months old and baby more than 3 months old. And then list the virus that can cause the meningitis in the pediatric age group. And what vaccine available for those organisms that cause meningitis? So please list some of it. So anyone would like to answer the question?
Hello, I would like to try. Okay, so for the first one, what are the causative organism of meningitis according to age? So for neonate, which is less than 1 month old, the organism could be group B Streptococcus and E. coli. For baby age 1 to 3 months old, the organism could include GBS, E. coli, Haemophilus influenza, and Streptococcus pneumoniae. And for baby more than 3 months old, the causative organism could be Streptococcus pneumonia, Haemophilus influenza, and Neisseria meningitidis. So for the second question, what is a virus that can cause meningitis? So it can include enterovirus such as Coxsackie virus, mumps, herpes simplex virus, herpes zoster, HIV, measles, and influenza virus. Okay. So the last question is, what are the vaccine available? So we have first one a meningococcal vaccine, which is for Neisseria meningitidis, and then Haemophilus influenza type B vaccine, and then the last one is a pneumococcal vaccine for Streptococcus pneumonia. Okay, I think that's all.
Okay, so let's see the answer. Okay, so this is the causative organism according to the age. So all of it has been mentioned by Alia. Okay, next. So the virus, there are a lot of viruses that can also cause meningitis, like enterovirus, mumps, HSV, herpes zoster, HIV, measles, and also influenza. And the vaccine, another vaccine that we can add, the additional vaccine like varicella zoster vaccine. This one is an additional one. Okay, next question. Okay, so question 2. Give 3 symptoms of suggestive of meningitis. And then what 3 signs of meningitis that could be found in physical examination, and how to confirm the meningitis. So who would like to answer this question?
May I answer this question?
Okay.
Okay. For symptoms of suggestive of meningitis, we use fever and neck stiffness and altered mental status. That's for symptoms. And for sign in physical examination, Koenig and Brudzinski. Koenig for we raise the leg and elicit pain, and Brudzinski we lift the head and the leg of the patient will try to rise to reduce pain. And bulging fontanelle in infants, probably due to increase ICT. There's 3 signs. And
is there any demonstration? Is there any demonstration of the Koenig and the Brudzinski or not?
And the what? Can't hear.
If not in your OSCE, you need to add. You need to put the meningeal irritation sign as a picture in your OSCE.
Oh, so
after that, no issue. You will complete it after that. Okay, continue.
Okay. How to confirm meningitis? We confirm by doing lumbar puncture. We to elicit with a differentiate between viral or bacterial meningitis by the protein count, which is increased in protein count, which increase in viral in bacterial, and the presence of neutrophils in bacterial meningitis and lymphocytes for viral meningitis. That's all.
Okay. Right. Okay. So let's see the answer. Okay. So what Hassan has answered is true. So the classic triad for the meningitis, it as a fever, knuckle rigidity or neck stiffness, and altered mental status. However, in children, usually they can also present it with a non-specific sign and symptom first. It could be like flu-like illness such as fever, headache, lethargy, irritability, nausea and vomiting, and the pediatric age group also can present it with diarrhea, abdominal pain, or sore throat. And then later, when the disease progress, so it will be more specific, like neck stiffness, and they also can have a non-blanching rash, molted skin, and also if it is severe, it can lead to seizure, paralysis, and also go to shock. And then for physical examination that suggests the meningitis, we can do the meningitis test. I'm sorry because I forget to put the picture or on how to do a Kernick sign and Brzezinski sign. Basically, Kernick sign, when the patient will feel a pain and have a resistance when we do passively knee extension with the hip fully flexed. And then for the Brzezinski sign, okay, when we try to bend the head forward, the knee and the hip will be flexed automatically. Okay, and then other sign on physical examination that we could find is a non-blanching rash. Non-blanching rash, it indicates a meningococcal disease. Usually the rash will be purpuric or PTK, and then in the infant we must check the fontanelle, so it might be bulging, indicate increased ICP. Okay, so for the confirmation test for meningitis is a gold standard to do a lumbar puncture. And later, next question we will discuss what the result of the lumbar puncture. Okay, next question. Okay, so question 3. A 3-year-old boy child presented with a fever, photophobia, and seizure. He was planned for lumbar puncture procedure. So what are the contraindications of performing lumbar puncture? And then explain the CFS result for those situations, which is acute bacterial meningitis, viral or aseptic meningitis, TB meningitis, and fungal meningitis. Okay, anyone would like to answer?
I would like to answer for the question. So for the contraindication of performing lumbar puncture, first we need to patient with increased intracranial pressure with symptom like vomiting, headache, change in vision, change in vision, cannot do must be ruled out first before doing lumbar puncture. So it is contraindicated. And then bleeding tendency also need to be contraindicated for lumbar puncture. Those with local infection at the site of lumbar puncture also to contraindication of lumbar puncture, and those with hypertensive encephalopathy. And then for the CSF result, for bacteria, usually it is turbid in color with increase in white blood cell count and protein, but reduce in glucose. For viral, as mentioned previously, it is clear with normal glucose but high in protein and white cell count. For TB, usually it is opaque in color with increased white cell count, especially lymphocyte, and reduce in glucose. However, protein increase. For fungal, usually it is cloudy with increased white cell count and protein, but the glucose can be low or reduced.
Okay, thank you. Okay, let's see the answer. Okay, so the contraindication of the lumbar puncture. First, we must check the patient either they have a sign and symptom of the increased ICP, such as altered consciousness, abnormal posture, when they have a focal neurological sign and abnormal pupil reflex. And other than that, check that the patient hemodynamically stable or not. And then when the GCS is less than 8, it also contraindicated. And when there is a history of seizure, we must check that when the seizure occurs. So because we cannot do immediately after a seizure occur, and then check the bleeding tendency. Either the patient have any bleeding tendency, and then check for the skin infection at the site of the lumbar puncture. And it is also contraindicated to do lumbar puncture in the patient with the hypertensive encephalopathy. Okay, next. Okay, so for the Cfs Csf result, okay, as stated here, in acute bacterial meningitis, the appearance usually cloudy and turbid, and they have an increase in the leukocyte and also protein. Usually the leukocyte count is very high, and then the glucose is low. And then other confirmation tests or specific tests that we could do to confirm the acute bacterial meningitis, we also can do CSF gram stain and culture and send for CSF bacterial antigen. And then for viral or aseptic meningitis, the appearance will be clear and then have increase in the leukocyte, predominantly lymphocyte, and then slightly increase in the protein. However, the glucose is normal, and then we can send specifically for PCR, CFF PCR for virus. And for tuberculosis meningitis, the appearance will be opaque and the leukocyte will be increased. At early stage, the polymorphic neutrophil will be predominant, and then later it will be lymphocyte. Then protein will be increased, however the glucose decrease. For specific investigation, we can send for smear for AFB and then send for gene expert MTB test will be positive in the CFS. And then for fungal meningitis, the appearance could be clear or cloudy and then increase in the lymphocyte count, increase in protein. However, the glucose will be normal or low. So the usual causes organism of fungal meningitis usually cryptococcal. So we send for CSF for cryptococcal antigen, and then we also send for HIV test usually because fungal meningitis usually occur in the immunocompromised patient. Okay, next. Okay, for the first question, okay, 1 year old, 5 month old child presented with a fever and convulsion. So the lumbar puncture was done. The CFS result investigation show protein 80, glucose 2.0 millimole per liter, white cell count 500 millimeter cube. Okay, so give diagnosis and 3 common organism and state a 3 long-term sequelae of this condition.
So I would like to try. So based on this, the protein is high, the glucose is low, and the white cell count is high with more towards polymorphonuclear cells. So I think this is bacterial meningitis. I think it is bacterial meningitis, and the causative organism could be meningococcal such as Neisseria meningitidis ataupun pneumococcal such as strep pneumonia and influenza. Okay. And state the 3 long-term sequelae. The complication that could happen, the patient may develop cerebral palsy, the patient may also develop epilepsy or having developmental problems, having sensory neural deafness, or yeah, I think so.
Okay. Next. Okay, so the diagnosis for this condition is a biogenic meningitis. It can be either so the organism could be caused by pneumococcal, influenza, and also meningococcal. Then for the complication of the meningitis, we can the patient can develop acute complication like sepsis, septic shock, disseminated intravascular coagulation, coma, and also seizure. And other complication usually in bacterial meningitis survival. So they could have sensorineural deafness, hydrocephalus, CP, epilepsy, and also behavioral problems. Okay. Next. Okay, so based on this table, either it is a normal, viral, or bacterial meningitis, and validate your answer. And then for this condition, assume that the patient is a 6-month-old. Okay, would you like to answer?
Yes. Assalamu alaikum. Assalamu alaikum. Farah. I'm going to close the session now to allow the male doctor to go for praying Jumaat. For our female staff, you can continue, and please make correction of the slides and let me see it after that. Okay. See you inshallah in the next time with our teaching, remembering me about that. Okay. Thank you very much.
Okay, thank you, Doctor.
Thank you, Doctor.
Assalamualaikum.
Thank you very much, Doctor.
Thank you, Doctor.
Assalamu alaikum.
Waalaikumsalam warahmatullahi.